Good morning, everybody. This is Bob Moorthy, Ramana Moorthy from Indianapolis, Indiana. I wanted to share with you what's going on with white dot syndromes and give you an update on that today. So I like to call white spot or white dot syndromes inflammatory chorioretinopathies. And my mentor, whom I trained with, Dr. Lee Jampol, who I considered one of the foremost experts on white spot syndromes, taught me a lot 25 years ago. And he continues to teach us today with many of his ideas. And I hope that with my training with him and experience over the years that I can impart some of his knowledge, which is vast, on this subject. And I humbly will approach this topic to see if we can answer a few questions that you may have about these syndromes. I'll start with the poll question. Let me get you onto the slideshow here, and we'll start with the first poll question. So we have kind of a mixed bag of ideas here. So although many viruses have potentially been implicated in the cause of AMPI, and AMPI is likely a viral-related illness because patients do have a viral prodrome, none has been definitively found to be the etiologic agent. Most recently, we know that viruses such as hand-foot-mouth disease virus, Coxsackie virus A and B, and other viruses, paramyxoviruses, have been associated with these white spot syndromes, and particularly with AMPI. The etiology of AMPI remains unknown, and because it's been reported with viral syndrome, there have been associated other systemic illnesses. The most serious of which, as ophthalmologists, that we need to keep in mind is cerebral vasculitis, because this potentially can be fatal. The recognition of meningismus and other signs of meningitis to suggest that there may be active vasculitis going on in the patient in the central nervous system is very important when you talk to a patient who has AMPI. If they have severe headaches, nausea, vomiting, meningismus, that certainly indicates that they potentially could have a fatal associated disease process, and they would need urgent neurologic evaluation and more aggressive treatment, probably with systemic corticosteroids and admission to the hospital. It usually affects otherwise young, healthy adults. This condition is infrequent. I probably see in my uveitis and retina practice maybe 2 or 3 cases of AMPI a year between the four of us that are in our practice. The history is usually of sudden onset of bilateral visual disturbances in vision. And typically patients have paracentral scotomas or scotomas. They usually are not photopsias present. These may be asymmetric in terms of the severity of vision loss in one eye compared to the other. And again, a review of systems may reveal a viral illness or viral prodrome prior to the onset of the disease process in the eye, and there may be associated cerebral vasculitis, associated neurologic symptoms. Usually, as you know, this disease is very characteristic since it was originally described by Dr. Gass in 1968. There have been, of course, numerous reports on AMPI since then. Creamy, yellow, gray-white lesions that are flat and appear to be in the subretinal or RPE level occur in the posterior pole. There's usually very little inflammatory reaction in the vitreous. It's maybe very mild to none. And there are central scotomas, as I mentioned. These lesions usually rapidly resolve. OCT imaging usually reveals disruption of the inner segment, outer segment, or ellipsoid zone, and the inner segment, outer segment junction or ellipsoid zone. And there's usually quite a good return of vision in most cases, although pigmentary disruption may be present in the macula. The visual return may be a little bit less in other related diseases, such as the so-called ampigynous version of this AMPI. The subretinal fluid collections may be seen on OCT, and that is something unique that we found since high definition OCT was available, that we may be able to see subretinal fluid in cases like this. Here is again the clinical picture of a patient who has bilateral disease with various stages of lesions that are healing. You see on the left here, some of the whiter lesions are more acute, and the central areas of clearing that you see. And then on the other side too, that you may see some more peripheral lesions that may be getting more pigmented, suggesting that they're in various stages of healing. Usually fundus photography and fluorescein angiography can be performed, and the classic description of inflammatory diseases arose from the original description of AMPI in 1968. That is, early blockage and early hypofluorescence and the fluorescein angiogram followed by late staining of these inflammatory lesions. ICG angiography may be interesting because this may show more pronounced hypocyanescence of these active inflammatory lesions, and the hypocyanescence persists throughout the angiogram. Again, the OCT will show evidence of hyperreflectivity of the retinal pigment epithelium along with disruption of the ellipsoid zone and presence of perhaps foveal subretinal fluid. OCT angiography, which is a newer tool that not all of us have access to, may show a dramatic reversible ischemia of the choriocapillaris that is quite unique to AMPI and results in our understanding, I think, of the pathogenesis of this disease perhaps, and also to understand why do we see visual return in these cases. So here's the a color photograph again of that same picture of AMPI, followed by the early phase of the fluorescein angiogram. You see the very, very early laminar venous phase here, and you can see after complete arterial filling that these lesions are hypofluorescent centrally, those same white lesions that you saw, and in the late phases of the angiogram, you'll see this late staining. So early hypofluorescence, late staining, typical of inflammatory lesions in the retina and or choroid. Here you can see the appearance of another case of AMPI, another bilateral case, but here's the left eye, and you can see the right eye here on the fluorescein angiogram. The early phases hypofluorescence early, late phases staining. Here's the corresponding ICG to that patient, and you can see this is my friend Al Vitale's case, and this again shows large areas, perhaps more hypocyanescence that you would probably see clinically in terms of lesions. So you may see more widespread disease process involving the posterior pole. Here's the OCT angiogram, and again, this is from another source. I don't have access to OCT angiography in my practice, but in the medical center we do, or we're going to be getting one. And here we can see this in the early phases, this fluorescence or poor filling, if you will. I'm sorry, that's not, fluorescence is not the right term, but poor filling in the early phases of this and hyporeflectivity of the in these areas of ischemia of the choriocapillaris. And as the disease continues to fade, and you can see the reversibility of this ischemia of the choriocapillaris. These lobular areas of ischemia fill and become more normalized as the disease heals, indicating, well, this is why vision usually returns in AMPI. The differential diagnosis can include other white spot syndromes, such as serpiginous choroidopathy or amphigenous choroidopathy. Relentless placoid chorioretinitis may also occur in a similar fashion. Multifocal choroiditis, which we'll speak about, can also be in the differential because the white spots can, when they're actively inflamed, can mimic those. Syphilis, sarcoid, and tuberculosis also should be included in the differential, along with Bartonella chorioretinitis, which is usually a focal chorioretinitis when it does occur and looks more like toxoplasmosis. Pneumocystis choroiditis in patients who are severely immunocompromised, such as HIV positive patients, can look very similar to some of the pictures of AMPI that I showed you previously. Primary CNS lymphoma and primary vitreoretinal lymphoma can have sub-RPE level infiltration and can look similar to AMPI. The medical therapy is usually not needed for isolated ocular involvement, although oral corticosteroids may speed resolution. Its efficacy has not been proven. High-dose corticosteroid treatment is suggested if the patient, of course, has life-threatening cerebral vasculitis. Rare complications can include the development of choroidal neovascularization, and permanent reduction of vision and persistent scotoma are possible if there's excessive subfoveal RPE scarring or scarring from choroidal neovascularization. We can see that AMPI is a unique disease, but you'll see some parallels to other diseases that we'll talk about. Here's the next question. What is the most common cause of vision loss in birdshot uveitis? A, choroidal neovascularization. B, chorioretinal atrophy of the macula. C, cystoid macular edema. D, optic atrophy. And a lot of people thought choroidal neovascularization, and some people thought cystoid macular edema. So this question, any of those changes can potentially cause vision loss in birdshot uveitis. But cystoid macular edema by far presents the patients with early cases of vision loss and can can result in long-standing vision loss in patients. So cystoid macular edema by far is the most common structural complication of the uveitis, and likely the most common cause of central vision loss in uveitis. Long-term vision loss, of course, can result from optic atrophy and chorioretinal atrophy involving the macula and diffusely the entire retina in some cases. Choroidal neovascularization is distinctly less, it can occur, but it is relatively uncommon in birdshot uveitis. It is probably more common than it is in AMPI, but it's still relatively uncommon. The epidemiology is typically that it affects Northern European patients more commonly, and as you know, HLA-A29 testing is often positive in these patients. When you see phenotypic evidence of birdshot, this test confirms the presence of birdshot, doesn't establish the diagnosis, however. Mean age of patients is usually in the presentation in the early 50s, although I have patients who are 30 years old who have active and severe birdshot retinochoroiditis in my practice. There's a slight female preponderance. Patients usually present with floaters, photopsias, some level of nyctalopia or nighttime visual dysfunction. There may be dyschromatopsia, especially if there's cystoid macular edema, and with more long-standing disease, severe vision loss can occur. Patients with birdshot typically have subtle, creamy to pale orange lesions that radiate mainly away from the optic disc along the choroidal vessels, nasal to the disc, extending into the periphery, and they're often broadly distributed. Often as if somebody took a shotgun with birdshot-like pellets, that's where the name came from, and shot the fundus with these little pellets, and so you see these pale orange lesions throughout the periphery. Only very late in the stages of the disease do these lesions become atrophic looking, and I'm talking about decades after the disease has been present. There's usually minimal to no anterior segment inflammation, and there may be variable amounts of vitreous inflammation, which can sometimes be very mild, and in some cases non-existent even with substantial retinal disease. The fluorescein angiogram may show retinal venular leakage, disc leakage, and cystoid macular edema. And the birdshot lesions show up on fluorescein angiogram depending on the stage of the disease. Early on, you may not see that. ICG angiography may be much more beneficial. Cystoid macular edema may be present, and narrowing of arterioles with late stages of the disease is not unusual. Here you can see a typical case. I hope you can see the fundus picture well. This is one of my patients who has obviously bilateral disease, but this patient has radiating these creamy lesions. They're subtle. They're not thickened and elevated usually. They're very subtle and flat, but you'll see these lesions following the choroidal vascular pattern, radiating nasally away from the disc, and following the vascular pattern of the choroidal vessels rather than the retinal vessels. And you can see the subtle kind of blurring of the disc margins here, and there may be even a subtle disc edema. And you can see in the fluorescein angiogram the disc staining, the perivascular leakage, and in the late phases you may see some very mild variable amounts of cystoid macular edema and petaloid pattern of CME. OCT may show cystoid macular edema. There will be variable levels of outer retinal atrophy. There may be significant retinal thinning with long-standing disease. Enhanced depth imaging may show choroidal thinning with advanced disease and may or may not show choroidal thickening, but choroidal thickening probably be most apparent in the peripapillary choroid around the optic disc. The OCTA may show some very subtle reduction of deep retinal capillary plexus density going along with the retinal vascular changes that we may see with this disease process that explains that. And it may explain why, in some cases, neovascularization elsewhere, meaning retinal neovascularization, can develop in birdshot uveitis. Very interesting disease in that way. And again, the fluorescein angiogram can be very useful to see the retinal vascular leakage and CME. Here's the ICG angiogram, which I think can be very useful as well. You can see the composite image here of a fluorescein angiogram on the left, and on the right side you see the ICG angiogram. And spots are usually hypocyanescent in the posterior pole, and there may be more or larger spots than are visible clinically. And I use this often to help me guide and see how the patient is doing in terms of disease progression. Especially when you see the patient with this as an acute presentation pattern, you may often see with good treatment and resolution of many of these hypocyanescent lesions on the ICG angiogram. Testing is usually, this is a clinical diagnosis based on the patient's clinical history, and the clinical appearance rather than any specific lab test. The HLA-A29 testing, if it's positive, provides us with strong evidence that it is birdshot, because there is a 95% correlation and concordance between HLA-A29 and the presence of birdshot, but it is not a diagnostic test. Remember that up to 8% of some populations of Caucasians can have that allele present, and 8% of the Caucasian population, at least where I live, does not have birdshot. It's not that common. So randomly checking this on any uveitis patient is useless. So I would check this kind of testing specifically when you have the clinical pattern, so that you can nail the diagnosis and call it birdshot. I have patients who are A29 positive that have very typical phenotypic birdshot. So, and I have patients who are HLA-A29 negative who have very typical phenotypic birdshot. So it is a clinical diagnosis. Again, the differential diagnosis, of course, is broad, and you have to consider other things. Sarcoid can cause perivascular inflammation, and CME can cause choroidal inflammation. Those sarcoid lesions look more juicy in the choroid, if you will, and there can be more punched out choroidal scars with atrophic scarring with sarcoid with disease progression, whereas you don't see that much with birdshot. Intraocular lymphoma is in the differential of any older patient after age 50 who presents with vitritis. Syphilitic chorioretinitis, of course, is the differential of any uveitis. Multifocal choroiditis in very late stages of birdshot may look similar. Punctate endochoroiditis, because some patients, and this is really kind of the same as multifocal choroiditis. Multiple evanescent white dot syndrome, especially when the patient may have disc edema, perivascular staining, that kind of thing can be seen in MEWDS in early cases. And TB, of course, is in the differential of all uveitis cases as well. Medical therapy, I think it is crucial to understand that birdshot is a disease that probably cannot be cured. We know that from very good evidence with long-term studies shown at the Basketball Eye Institute and ongoing studies done through the site study on birdshot, that we know that short-term inflammatory flare control can be achieved with corticosteroids systemically by even intravitreal periocular injections. But due to the bilateral and chronic intermittent local nature of this therapy, local therapy is not a viable long-term option, but may be useful for controlling cystoid macular edema. Long-term control of this disease, in my opinion, requires immunomodulatory medications. This is needed in most patients. However, there are many patients who are minimally symptomatic, if at all symptomatic, with phenotypic evidence of birdshot. Some uveitis specialists believe that these patients, because of the lack of symptoms, can be followed. There is certainly a subset of patients, about 10%, that have very mild disease that may progress so slowly or so infinitesimally slowly that you are not able to detect that the patient is losing vision over the course of years. Those patients potentially could be monitored. But the vast majority of these patients go on to lose vision without aggressive therapy with immunosuppression. Mycophenolate is most commonly employed in these patients because this is lifetime immunotherapy. Some patients use a combination, some doctors use a combination of mycophenolate and cyclosporin, along with the oral prednisone, which can be tapered down or off. Long-acting steroid implant can be very beneficial, but remember, multi-year control. These fluocinolone implants last for 3 years. They need to be replaced. Guaranteed likely that they will develop cataract after the first year to 2 years of the implant placement, after the first implant placement. And remember that there's about one third of these patients go on to have significant enough glaucoma that they may require glaucoma surgery. So that's very important to remember with the fluocinolone acetonide implants, and that reimplantation will likely be required in birdshot at the end of 3 years, and multiple implants may be required over the course of the life of the patient. Monitoring of these patients is very difficult. I think fluorescein angiography can be useful with the disease is very active, but in chronic treated disease, it can be very difficult to follow the patients and see how they're doing. OCT can be helpful to assess cystoid macular edema and presence of refractory. Visual fields, computerized or Goldman visual fields can be utilized to determine retinal sensitivity and map blind spots. And these paracentral scotomas, perineural scotomas, are common even in early phases of the disease, and longitudinal follow-up annually with visual fields is very important. And I think that there's certainly a role for ICG angiography, as I mentioned, which may reveal more choroidal lesions and could be used to assess the response to therapy. In addition, electroretinography has been touted to be very useful to evaluate photoreceptor dysfunction, especially in advanced disease, and to follow how the disease is progressing on an annual basis. I think this is very useful when you have a laboratory that has standardized ERG protocols, and where this standardization will allow appropriate ability for repeatability and accuracy of this test. There is substantial variability in lab quality in my experience with ERGs. So if you're lucky enough to have a very good technician that can do good ERGs, and an electrophysiologist that does ERGs in your institution, this can be a very useful way to standardize and follow patients. So these patients may have some improvements in the visual fields in ERG with treatment, especially with immunomodulatory therapy, but this is a typically relentless, progressive disease that we can slow down with immunosuppressive therapy, but we cannot cure, and it is a lifelong disease. Disease complications, as we mentioned, cystoid macular edema, epiretinal membranes, and vitreomacular interface abnormalities are quite common with Birdshot in my clinical experience. So it is not uncommon to see patients having partial vitreous separations with hyaloidal attachments to the optic disc and evidence of epiretinal proliferation in the surface of the macula. And this can arise probably from associated perivascular sheathing and inflammation as well. Moderate to severe vision loss from retinal degeneration can occur over many years. Optic atrophy can develop. Choroidal neovascularization, as I mentioned, is rare but can happen. Nyctalopia can become more severe over time. Reduction of color perception and contrast sensitivity over more advanced macular disease, and progressive visual field loss of disease. There is apparently some increased risk of normal tension glaucoma that is related to choroidal thinning and ischemia associated with this disease and birdshot uveitis. The prognosis is guarded because some patients, about 15 to 20, in some studies, 15 to 20% of patients with birdshot have a favorable prognosis. But the largest studies with long-term follow-up suggest that the prognosis is quite poor without treatment. And this is a function of disease duration and independent of systemic corticosteroid use. However, large cohorts have shown that a 5-year cumulative incidence of visual loss of worse than 2,200 is about 20% with birdshot. That induction of long-term remission is possible in some patients. I believe that's clearly possible, but it is not that doesn't occur in everyone. I would suspect that it's around maybe 10 to 20% of patients that we can see this kind of effect, and that may be that subset I was telling you about that have milder disease that respond well. Poll question number 3, next disease process. Which of the following features of multiple evanescent white-Down syndrome is correct? A, it is more common in males. B, it's usually bilateral. C, choroidal neovascularization is common. Or C, it may follow a viral prodrome. Looks like most of you got it. So this disease, multiple evanescent white dot syndrome, which we'll discuss next, it often does follow a viral prodrome, but it's uniquely, typically a unilateral disease, although there are bilateral cases that can occur, and I'll show you one. But it may present a spectrum of disease from idiopathic blind spot syndrome to multifocal choroiditis / panuveitis type syndrome. So some people believe that this is a phenotypic manifestation of the same disease that's variable based on the immunogenetic makeup of the patient. That's what I think the prevailing theory is. At least that's my teleologic understanding of this disease process. MEWDS is a benign process in general. It tends to occur most commonly in young, healthy women, and it may follow a viral prodrome. Usually there's a sudden onset of blurred vision in one eye. Patients may have photopsias. They may present with paracentral scotoma. They may be aware of a shadow in the temporal visual field with an enlarged blind spot. And often the blind spot may be shimmering, although this is not always required with the diagnosis. My general impression is that patients with active disease will have the shimmering kind of scintillations within that blind spot. The features usually are of gray, white, poorly demarcated, and subtle gray lesions scattered around the posterior pole. These are 200 to 500 microns in size. The acute lesions may be hyperfluorescent and I will show you hyperautofluorescent too on the autofluorescence imaging, and I'll show you some autofluorescence imaging here. And this is where autofluorescence is one of the diseases where I really like to use autofluorescence because I think it would be highly useful in picking up some of these lesions where you can't see them clinically very well. There can be orange granular pigmentation of the fovea, which some people believe to be the sine qua non of this disease, because the white spots may fade and they're very transient. Within even 1 to 2 weeks, the granular pigmentation may persist a little bit longer, but is very common, very prevalent in the early phases of disease. There's usually minimal vitreocellular reaction, if any, and there may be a prominent sectoral defect in the area most involved with the white spots. There may be an apparent pupillary defect, especially in the presence of disc edema, which can be present in these cases. There may be subtle clinical signs as well in the absence of symptoms. That's rare, but that can happen. Rapid resolution of white lesions is the result, and usually the vision returns to normal within 2 to 12 weeks. There is slower resolution of the granular macular pigmentation, as I mentioned. RPE scarring is very infrequent and very rarely results in permanent visual field loss. Here's a patient with the granular pigmentation of the fovea that you can see, one of my old patients, and there's granular pigmentation here. There may be a little blurred at the disc margin here, but it's hard to see the white spots very easily here in this eye. But here you can see in Dr. Goldstein's pictures, these beautiful pictures of white spots. This almost looks like a necrotizing retinitis, like outer retinal necrosis. But this is a great case of multiple evidence of white dot syndromes. You can see confluence of some of these spots, and I'll show you that on the autofluorescence imaging. Here's another one of her beautiful pictures of the patient with the granular pigmentation of the orange yellowish kind of granular changes in the central macula in active MEWDS. Fluorescein angiography may demonstrate the typical wreath sign or collections of punctate hyperfluorescent spots at the site of a white lesion, and I'll show you what that means. The ICG may show multiple hypocyanescent spots that are persistent throughout the angiogram, even in the late phases, and they're clustered around the optic nerve head and the posterior pole. ICG angiography sometimes will reveal bilateral disease, even an asymptomatic eye, and I'll show you a case of that in a moment. Visual field defects visual fields usually reveal in the large blind spot, as I mentioned. And OCT may reveal subtle transient disruption of the ellipsoid zone and hyperreflective multifocal debris in the ellipsoid layer that protrudes into the outer nuclear layer, and then gradually this goes away with the disease process as it heals. Autofluorescence is a very, very useful tool and often overlooked with this disease process. And I'll begin with autofluorescence imaging here with active disease on some of my patients. This is a beautiful picture of a patient who presented, as you can see the dates here, with acute disease with numerous spots surrounding the macula and of course around the optic nerve head. Very typical kind of distribution of spots, these hyper autofluorescent spots. And in follow-up, look, the spots, some of them you can actually see they've spread. There are a few newer ones perhaps that you see, but many of the old ones have subsided and gone away. I apologize for the difference in the exposure time for the autofluorescence imaging, but there's improvement within 2 weeks of the central lesions for the most part. Here is a patient's, same patient's fluorescein angiogram and ICG. You can see the fluorescein angiogram showing the hyperfluorescence, and this is in the late phases of the angiogram of these numerous white spots and throughout the nasal mid-periphery. And then you can see on the ICG angiogram probably a much more clear representation of the hypocyanescent spots that are the active white spot lesions in the acute phase of the disease. This picture is another patient that had multiple evanescent white dots, but look at the two things here. The wreath sign, this is a great example of what a wreath sign is. So you can see this wreath of hyperfluorescence around the central, relatively hypofluorescent spot. This is one of the white spots, and that's a wreath sign. So this is a wreath, like a Christmas wreath, if you will. And in the image on the right side, you can see that the patient has more confluence of this hypocyanescent spots on the ICG angiogram, and same patient. Very interesting change. And again, look at the RPE changes in the central macula. Isn't that interesting? You can see this even in the late phases of the ICG angiogram here. Here is a representation of some of the ISOS disruption and some of these excrescences that get into the outer nuclear layer here. Again, very characteristic. And as this heals, you will see resolution of these changes over time. Another patient showing the fluorescein angiogram of the widespread nature of these lesions in the posterior pole. Typically, these spots are not going to be visible in the far periphery. And there may be other signs, other wreath signs that you can see on this fluorescein angiogram of this patient. Look at also the vascular staining. This is not an atypical feature in the late phases of the angiogram of multiple evanescent white dot syndrome. Here's a patient who I was telling you about earlier that had bilateral disease. His symptoms were mainly in the left eye, but he actually had some active disease in the right eye as well. And these both resolved in 2 weeks. Again, it is more common in young, healthy women. And the differential diagnosis includes acute idiopathic blind spot enlargement, which some people believe is the same disease, but without the white spots, or the white spots may not be visible. Acute zonal outer occult retinopathy is a rare condition that can look like this. The fluorescein angiogram, the OCT changes sometimes can mimic the changes that you see with multiple evanescent white dot syndrome. And it's in the same demographic group that's affected with this condition as well, typically young and more commonly in women than men with AZOOR. Multifocal choroiditis is a spectrum of the disease process. Syphilitic retinitis can look similar to multiple evanescent white dot syndrome, and acute macular neuroretinopathy can be a subtle evasive disease process that I'll show you pictures of later that potentially can also be a condition that is in the differential diagnosis of MEWDS. Typically, no therapy is required for multiple evanescent white dot syndrome. Corticosteroids can be used if there's significant optic nerve head edema or reduced vision, but usually are not necessary. The disease improves over the 2 to 12 weeks. Disease-related complications such as permanent scotoma and large blind spot can occur. The development of a more permanent posterior uveitis has been associated with MEWDS. There are cases of multiple evanescent white dot syndromes often occurring in conjunction with other white spot syndromes such as multifocal choroiditis, panuveitis. I've certainly seen that, and many of you may have seen that. So that's why I think people believe that these diseases may share a common pathogenesis, but represent different phenotypic manifestations of the same underlying pathophysiologic process. We're going to move on now to talk about another condition that can be very difficult to treat. Multifocal choroiditis and panuveitis also affects patients who are younger, but it has been reported in all age groups. These patients are older than the MEWDS age group or AMPI age group in my experience, but it can occur in a little bit more commonly in women than men. Some authors believe that multifocal choroiditis, panuveitis, punctate intrachoroiditis, and progressive subretinal fibrosis uveitis syndrome, and of course, as I mentioned, MEWDS, are different phenotypic manifestations of the same disease. And as far as multifocal choroiditis, panuveitis, punctate intrachoroiditis, progressive subretinal fibrosis uveitis, a lot of people lump those together and call it idiopathic multifocal choroiditis. And that's very important. And I think that's a good takeaway point. And from my mentors, Dr. Jampol and Dr. Bird, both who feel like this, again, the commonality of these diseases is far more important than the differentiation of these diseases. Historically, these patients will have visual disturbances, floaters, scintillating scotoma, and I rely on the scintillating scotoma and enlarged blind spot often to determine, even if the eye itself looks quiet, whether the patient has activity in their disease or subclinical activity in the disease. And I use that as a subjective way, in part, to measure how well the disease is controlled and my choice of medications to treat this disease process. The choroidal lesions are often small early on, and the inner choroid active lesions may appear creamy white and hazy with less distinct borders, and as they heal, they may appear punched out. There may be hundreds of lesions, sometimes becoming confluent and quite large. There may be peripapillary involvement with peripapillary scarring. There may be diseases and lesions in various stages of disease evolution that may be present, with several lesions being same age and pigmented and clumped, another being more active. There may be a variable amount of vitreous and anterior chamber cellular reaction, and vitritis and anterior chamber reaction is typically more common with this disease process than it is with MEWDS or AMPI. It is often bilateral, although there can be sequential involvement of the eyes. But I also have patients who have distinctly unilateral disease for more than a decade or 2 decades and never develop involvement in the fellow eye. There may be variable amounts of subretinal fibrosis, and this usually results from the development of choroidal neovascularization or from inflammatory metaplastic changes of the pigment epithelium to result in subretinal fibrosis. So here's a patient of mine, a nurse who had presented, originally, this is after 10 years of disease, originally presented with only posterior pole involvement and originally with small lesions in the posterior pole and choroidal evascularization. This was many years ago prior to the availability of anti-VEGF therapy for the treatment of choroidal evascularization. She actually underwent subfoveal surgery and has good vision in this eye, but you can see with disease progression, multifocal lesions scattered throughout the periphery. Many times there can be hundreds of lesions of variable sizes, but most of these lesions are about the size that you see here in the periphery. They're about maybe 200 to 500 microns in size and variable amounts of pigmentation. Acute disease can be shown in fluorescein angiography. Early on in the early arteriovenous phase here, you can see the relative hypofluorescence of these spots where the arrows are. And in the later stages of that same, at the same time, that patient in earlier presentation, you can see active spots here. This is an area of choroidal evascularization that she had adjacent to the fovea on the side. Notice the disc staining as well, not uncommon with multifocal choroiditis, panuveitis. This is a clinical diagnosis, but in the presentation of this patient, even if it's the right demographic, a workup should be done. Especially in multifocal choroiditis, you need to rule out the most common things. Of course, sarcoid, syphilis, tuberculosis should be part of the armamentarium of testing of any patient with uveitis, but sarcoid, syphilis, and TB should be ruled out. The imaging can be very helpful. Fluorescein angiogram, as I mentioned already. ICG angiogram may show mid-phase hypocyanescence and greater numbers of active lesions than fluorescein angiography. And OCT may show ellipsoid zone disruption in active phases of the disease. Will show cystoid macular edema very well, which can complicate this condition, along with choroidal neovascularization. The differential diagnosis is very broad, as you might imagine, with multifocal choroidal disease processes. Sarcoid can cause this. Voutkoic disease, when it heals, can present with choroidal inflammatory lesions and multifocal lesions like this. Serpiginous choroiditis, simply because macular involvement of serpiginous can sometimes, and the presence of choroidal evascularization complicates serpiginous commonly, is also common in multifocal choroiditis. AMPI in acute phase lesions may look similar to acute phase multifocal choroidal lesions. And unilateral cases, we need to think about diffuse unilateral subacute neuroretinitis, which can also present with multifocal choroidal lesions unilaterally. Birdshot uveitis, especially in very late stages of the disease, can look similar to multifocal choroiditis, but there's usually a lot less vitreous cell, and usually this disease process doesn't involve the inner choroid. Differential diagnosis, again, continuing on, is very broad. One other thing very important in the Midwestern United States to include in the differential diagnosis is presumed ocular histoplasmosis syndrome. POHS, there is essentially absolute absence of vitreous cells. So the absence of vitreous cell, generally in the absence of any other symptoms, in an asymptomatic patient that looks with associated peripapillary chorioretinal scarring, punched out choroidal scars in the mid-periphery posterior pole, and choroidal evascularization are the triumvirate things that we look for in the diagnosis of presumed ocular histoplasmosis syndrome. Punctate intrachoroidopathy or choroiditis is considered a subset of multifocal choroiditis today, and I would regard it as that, although the risk of choroidal neovascularization is greater, probably in 2/3 or more of patients with PIC compared to multifocal choroiditis, where choroidal neovascularization complicates about 1/3 of patients. West Nile virus chorioretinitis can look similar to multifocal chorioretinitis, and syphilitic and tuberculous chorioretinitis can look similar as well. Primary CNS lymphoma, potentially anybody with vitritis, you need to think about that possible diagnosis. Dengue fever can also produce multifocal choroidal lesions, and that's in the differential diagnosis these days. The medical therapy is usually the use of systemic or periocular corticosteroids for the acute disease, and corticosteroid-sparing immunomodulatory therapy for chronic disease, especially in patients who have very severe cellular reactions in the vitreous and anterior chamber, and the presence of other disease-related complications, and especially those who have aggressive development of subretinal fibrosis. These patients have very guarded prognosis and really require aggressive immunosuppression. And antivascular endothelial growth factor agents should be utilized for choroidal neovascularization, which I think can certainly complicate more than 1/3 of patients with multifocal choroiditis, and as I said, more commonly in punctate intrachoroiditis. Laser photocoagulation can be utilized for extrafoveal choroidal neovascular lesions. Photodynamic therapy can also be utilized for choroidal neovascularization treatment. Corticosteroid implants can be utilized for unilateral asymmetric diseases and patients who cannot tolerate systemic medications long term. Here's a patient who was treated who had chronic cystoid macular edema from multifocal choroiditis. This patient had been on chronic low-dose maintenance steroids for years at 5 milligrams daily, but had persistence of cystoid macular edema. We placed her on mycophenolate and were able to reduce the dose of prednisone slightly, and were able to get rid of the cystoid macular edema and stabilize her vision. You can still tell on the fluorescein angiogram on the right that even after a year, there's still some subtle leakage and disruption of the pigment epithelium in the central macula from chronic CME. Disease-related complications, as I mentioned, choroidal neovascularization and multifocal choroiditis, typically in 33 to 35% of patients, and this is more common in punctate intrachoroiditis variant of multifocal choroiditis. Punctate intrachoroiditis, the only difference that I see is that the choroidal lesions typically occur more clustered around the macula. They're smaller, and there's much more preponderance to the development of choroidal neovascularization. Patients with punctate intrachoroiditis have a lot less cellular reaction in the vitreous, in my experience. So I'm not trying to separate these two. I think they are phenotypic manifestations of similar disease processes. Cystoid macular edema, as I mentioned, as I showed you previously, can complicate this. Scotoma and large blind spots are not uncommon, and visual impairment is not uncommon. Progressive subretinal fibrosis is the most severe complication of this disease that can result in total blindness. Here's a patient who has a subretinal fibrotic variant, a unilateral case of multifocal choroiditis. This patient was treated with a fluocinolone implant. She was intolerant of corticosteroids for various reasons, systemic corticosteroids, I mean. So she received intravitreal fluocinolone. This is in the left, an early case of active disease at presentation. You can see the vitreous haze, multiple choroidal lesions, and here, 3 years after implantation, you can see the patient developed choroidal neovascularization, subretinal fibrosis. Here's a subretinal fibrotic lesion that's not associated with CNV. This is from inflammation. And you can see that the lesions have grown and increased in number over the course of years, despite aggressive management. We'll move on to the next disease. I'm kind of trying to cover as many diseases as we can. I apologize if I ramble on, but this is a disease that these diseases are very interesting to me. What infectious cause of choroiditis can mimic serpiginous choroidopathy? Mycobacterium tuberculosis, non-tuberculous mycobacterioses, herpes simplex virus 1 infection, or syphilitic infection of the choroid. Let's see if everybody got this right, especially those of you guys in countries who have TB. Yeah, so MTB has to be considered in the differential diagnosis of serpiginous choroiditis. Serpiginous, the so-called tuberculous serpiginoid choroidopathy or choroiditis is not an uncommon manifestation of tuberculous uveitis in those countries where TB is endemic in particular. So this must be ruled out, and this term, this tuberculous serpiginous-like or serpiginoid choroiditis, is the preferred term to describe this. And this condition is quite different from serpiginous in the sense that it usually presents with much more vitritis, more multifocal lesions, and it's usually seen in endemic areas where TB is more common, although I have seen at least 2 cases of it here in the Midwest. And it's a little different than serpiginous choroiditis, where the etiology of the disease is unknown, and there's less inflammatory changes in the vitreous. Typically, there are no vitreous cells often that are present, certainly no anterior segment inflammation, and serpiginous tends to be, it's kind of men might be slightly more affected than women, tends to be present in the 4th to 5th decade. It can be sequential involvement, it may be asymmetric, but eventually it becomes bilateral. There's usually no systemic disease, but it has been reported to occur with concomitant sarcoidosis, Crohn's disease, vasculitic conditions such as periarteritis nodosa. There has been an association with this disease process and varicella zoster virus reactivation, although oral antivirals have not had any substantial effect in mitigating serpiginous choroiditis activity. Tuberculosis is a cause of tuberculous serpiginous-like choroiditis, and so we need to think about that in the differential diagnosis and the workup of a patient. But again, this tends to be a clinical diagnosis, and patients present with decreased vision, scotoma, and metamorphopsia. 2/3 of patients may present with scars in the fellow eye, indicating previous activity. And this is a relapsing and remitting disease, and the intervals between activity can be variable, sometimes weeks to even decades between activity. And that makes it that much more difficult to treat. I think there are 3 distinct entities for serpiginous choroiditis: the so-called classic peripapillary geographic choroiditis, which is the vast majority of serpiginous choroidopathy, and the macular serpiginous choroiditis, which is very rare. I have only 2 cases of that in my practice, and the amphigenous choroiditis. And there's also a subset called relentless placoid chorioretinopathies, which that subset represents a very uncommon subset of, it's a mix between ampy and serpiginous, and in relentless placoid chorioretinitis, it almost looks like a multifocal choroiditis type picture. So there's a large kind of a variation, a phenotypic variation of disease, where they've been kind of lumped together into these entities, although they may, the treatment is a little different for some of these entities. Classic peripapillary geographic choroiditis, the choroid may have grayish areas of active choroiditis that spread in a serpentine fashion centrifugally from the optic disc and progress towards the macula, ultimately resulting in vision loss. The symptomatic as the disease progresses, as the disease approaches the macula, in the peripapillary region, they may not have any symptoms from active disease. The natural history is that these lesions heal over 6 to 8 weeks and result in an atrophy of the choriocapillaris and RPE. Recurrences usually develop the edges of old lesions, but you can have skip lesions, and sometimes you can see peripheral lesions as well with this disease process, with serpiginous choroidopathy. Each recurrence increases the area of atrophy in a serpentine or pseudopodal fashion, and choroidal neovascularization is not uncommon, affecting more than 1/3 of patients who have this. Usually, the choroidal neovascularization is peripapillary or at the edge, leading edge of the chorioretinal atrophy. Sometimes you can see active lesions with choroidal neovascularization. Subretinal fibrosis can occur in up to 25% of patients. And in the retina may look thickened or opacified over the layer over the area of active choroiditis. Subretinal fluid may be present with active choroiditis or with choroidal neovascularization, and subretinal hemorrhage may also be present with active disease or with choroidal neovascularization, more commonly with choroidal neovascularization. The vitreous usually has minimal cellular reaction with serpiginous choroidopathy. Macular serpiginous, usually the serpentine lesions are more kind of smaller, and in the perimacular region, the visual prognosis is poorer for obvious reasons because the central macula is involved quicker. Amphigenous choroiditis or relentless placoid choroiditis is a hybrid, as I mentioned. They're multifocal gray-white lesions at the level of the RPE and choriocapillaris and choroid with outer retinal inflammation. New lesions may appear for up to 2 years. There may be variable amounts of anterior chamber vitreous cells, but certainly much more inflammation in my experience than we see with serpiginous choroidopathy. And this may involve the posterior pole and periphery, often randomly. And usually these patients respond to corticosteroids and immunosuppressive therapy. And their visual prognosis in general is better than the classic or macular serpiginous choroidopathy. Here's a classic case of the peripapillary helicoid or serpiginous choroidopathy, where we see bilateral disease. I'm sorry that I've had them switched here, the left eye on the left and the right eye on the right, but you can see old lesions. And in the left eye here, you can see more recent active lesions here that are in various stages of healing, affecting the fovea. Fortunately, the fovea is still spared in the right eye in this case. Here's a patient of mine that had active disease adjacent to old scarring. She's already lost central vision and unfortunately still has new activity. And here she did not have choroidal neovascularization, but did have some subtle subretinal hemorrhage at the leading edge of the lesion. Here's another patient where I have a composite here of mine that has perimacular involvement at the leading edge with this whitish appearance to the outer retina as well as the choroid, and you have 2 areas of active lesions, and you can see in the fluorescein angiogram it's hypofluorescent in the early phases, and in the late phases it stains. Again, kind of more typical of the acute inflammatory process of active lesions, as we saw with kind of like AMPI. So that's why AMP is in the differential diagnosis, and Serpiginous is as well. And here you can see a patient who has a kind of partially healing lesion where there was activity. This is that patient, another patient. And then here's the fellow eye where there's more active disease along the, and he's already wiped out the central macula on the left here. And here you can see a composite image of the right eye of a patient that has evidence of choroidal neovascularization that has occurred along with active disease. So you can see active disease with hypocyanescence along the margins and hypercyanescence in the central portion of this lesion, what is choroidal neovascularization. The fluorescein angiogram shows this leakage in the mid to late arteriovenous phase from choroidal neovascularization. And here on the opposite image, this was from this is the same patient that you saw in the last image, the color photograph. Let me go back here. So you can see this patient actually has CNV here, activity. You can see some exudate and some fluid here from the CNV, but there's some active lesion here as well, the active choroiditis. And here you can see the active choroiditis in the left eye. And so that's the same patient that I'm showing you on the composite images here. So on the ICG angiogram of the left eye, the active lesion, fluorescein shows staining of that lesion, not as intense as the choroidal neovascularization of the fellow eye. And on the ICG, you can see the persistence of the hypocyanescent lesion even in the late phases of the ICG angiogram. And on OCT, you can see evidence of subretinal fluid and intraretinal hard exudates that may be present associated with choroidal neovascularization in the right eye of this patient. Here's another patient with choroidal neovascularization. I'm sorry, this is a very red enhanced image, but there's choroidal neovascularization along the superior temporal margin of the superior temporal choroidal lesion. And you can see the fluorescein angiogram here showing the leading edge with subtle choroidal neovascularization and subretinal hemorrhage. And in the late phases, there's leakage along the area of choroidal neovascularization. So typically, this is a clinical diagnosis, serpiginous choroidopathy. Laboratory testing can include PPD skin testing, chest radiography, serologic testing, including quantifier and TB, and FTA, not so much RPR, but FTA, which is or anti-trypanoidal IgG testing, and ACE and lysozyme testing and chest X-ray are all important as part of the typical workup of any choroiditis patient with, that you're evaluating, or any uveitis patient for that matter. The quantifier on TB is particularly important because here we need to rule out the tuberculous serpiginoid choroiditis that I mentioned earlier, because it can look identical to the classic serpiginous choroidopathy. Fluorescein angiography and ICG angiography, as I already showed you, can be very useful in looking at active and older lesions. And fundus autofluorescence, although I haven't talked about it much, can be very useful as well, because areas of choroidal atrophy are usually hypoautofluorescent, but active disease may show subtle. It's not going to be as prominent as with MEWDS, but you will see in the active disease that there is hyperautofluorescence present. And the hyperautofluorescence may also be seen in regions of choroidal neovascularization. The spectral domain OCT may show in the acute phases a disruption of the ellipsoid zone, and chronic phases RPE atrophy and retinal thinning. And then, of course, chronic phases associated with choroidal neovascularization may see subretinal fluid and exudate, as I mentioned earlier. OCT angiography may show small, multiple geographic areas of inner choroidal and choriocapillaris non-perfusion with active lesions that do improve with treatment, but they don't improve to the extent that the AMP does. You may still have flow voids that remain with late stages of the disease. The differential diagnosis is broad. We've kind of covered it. The most important one to keep in mind is the tuberculous serpiginoid or serpiginous-like choroiditis. It's AMP, multifocal choroiditis, syphilitic, sarcoid, all those things, tuberculosis, all those things are in the differential diagnosis of this condition. Aggressive treatment is needed with medical therapy in this condition, and immunosuppressive agents are often used for the control of this disease process. I have used Imuran, I have used cyclophosphamide as well. And if you look at some of the data looking at long-term control of this disease, the longest period of remission with this disease process has occurred by using cyclophosphamide or particularly cytotoxic immunosuppressives like cyclophosphamide or chlorampicillin. These alkylating agents probably give us the greatest chance of long-term remission of this disease process, but they come at a price, obviously, because these agents are much more toxic from an immunologic standpoint. Corticosteroids, either locally or systemically, can be used for acute flares. With phobia-threatening flares, I will often give intravitreal, preservative-free triamcinolone, like Triessence, in the eye to control inflammation. That can be very effective to get the acute disease process that's phobia-threatening under control. Obviously, that runs the risk of glaucoma and cataract formation with repeated use, but long-term immunomodulatory therapy is very important with this disease process. The intravitreal fluocinolone implant can again be utilized to provide long-term 3-year inflammatory control, but it may not prevent recurrences that are beyond 3 years, of course. Choroidal neovascularization is treated with anti-VEGF therapy combined typically with corticosteroids or immunomodulatory therapy. Remember, with choroidal neovascularization with inflammatory diseases, choroidal neovascularization can't be managed only with anti-VEGF therapy. You have to control inflammation because the inflammation is releasing cytokines that are making VEGF, even promoting the activity of VEGF. So you have to control the inflammatory cytokines on the one hand and control the VEGF release on the other hand that is causing these inflammatory choroidal neovascular membranes to develop. So choroidal neovascularization, as I said, 35+% of patients can develop this with serpiginous choroidopathy. Choroidal atrophy is not uncommon. That can result from as the natural course of the disease, and these lesions heal. Subretinal fibrosis also is not uncommon. Retinal vasculitis and retinal neovascularization, although they've been reported, are extremely rare complications. Relentless placoid chorioretinopathy, as I mentioned, it kind of is a hybrid combination of AMPI and serpiginous. It's rare, bilateral, younger patients, men and women equally affected. Patients often present with photopsias, floaters, scotoma, or reduced vision. There is variable amounts of vitreous cells. Active lesions can look creamy white. They're smaller than AMPI. They're usually half a disc area or less. There may be numerous lesions that present throughout the periphery, and these can progressively increase in size. In some patients, these lesions can heal over the course of weeks and produce choroidal atrophy, but the visual prognosis of these patients is usually better in my experience, and these can often be managed with corticosteroids alone, but the length and duration of corticosteroid therapy may be as much as 1 to 2 years. There can be 50 or more lesions throughout the fundus, and that's a typical hallmark of the disease with relentless placoid chorioretinopathy. Vision loss and metamorphopsia and scotoma, when the lesions involve the macula, can occur. Subretinal fluid may be associated with acute lesions, and the lesions heal with preservation of visual acuity. Here's a patient with very late stage, kind of intermediate, partially healing phases of the relentless placoid chorioretinopathy. You can see disc edema and numerous white lesions here. So you can see why this, when you look at a patient like this, what is it? Is it AMPI? Is it multifocal choroiditis? Is it serpiginous choroiditis? Or is it tuberculous serpiginous choroiditis? All those things are in the differential. You need to think about the idea of a workup for this patient, including ruling out syphilis, sarcoid, TB. Once you've done those, at least those three, and make sure that if there are any other endemic diseases, infectious diseases that you may be considering before you embark on aggressive systemic corticosteroid therapy or immunosuppressive therapy on these patients. So here's the late phase, this same patient that I showed you earlier. This is later on after the control of the disease process. You can see numerous lesions. He's 2015 in this right eye. The disc edema has gone away. Of course, the vitritis has gone away. The view is much clearer. Here's the fellow eye, the eye that I showed you earlier in the left eye. And you can see the healed lesions, a lot of pigmentary disruption, but excellent central vision in this patient. Here's another patient with relentless placoid chorioretinopathy. Here's another valuable tool, this fundus autofluorescence imaging. You can see old lesions that are hypoautofluorescent and these acute lesions in the upper right that you see that actually represent new lesions that this patient has had and was symptomatic from. So this is a great way to follow the disease process. Here's this patient later showing progression of this disease process with newer lesions developing. She fortunately still maintains good central vision in each eye. And you can see the RPE level changes, the disruption of the ISOS junction, excrescences. These can look like, the same kinds of changes that we saw with MEWDS, with multifocal choroiditis, and also even with some cases of the multiple evanescent white dot syndrome. So these changes in the acute phase usually go away. So you can see that in these cases, there will eventually develop an area of RPE atrophy as these lesions heal, as you see in some of the older lesions on the picture here. The diagnostic testing using autofluorescence, RSFA, and ICG, as I mentioned, are all useful. Spectral domain OCT, I already mentioned, retinal photoreceptor disruption in the acute phases, and healed lesions result in RPE atrophy and rarefaction of the ellipsoid zone, along with atrophy of the choriocapillaris. OCTA can show, again, interchoroidal ischemia that may improve with treatment, but it can recur in adjacent and non-contiguous areas. And fundus autofluorescence can be very useful, as I mentioned, because heightenance of active lesions is often present. And laboratory use evaluation is done, but often not helpful because these patients will have, that's how you come up with a diagnosis. It's really a diagnosis of exclusion. There isn't any consistent systemic association. Again, treatment is usually oral corticosteroids and occasionally steroid-sparing immunosuppressive therapy. Relapses are common, but in my experience, RPC tends to kind of burn out and become less active over the course of a few years. Persistent placoid maculopathy was described by Dr. Jampol and Dr. Gulche within the last decade, and this is the disease that affects older patients. It's bilateral and symmetric. Its etiology is unknown. Patients usually present with decreased vision and central photopsias. They're usually a well-delineated jigsaw pattern, whitish plaque-like lesion involved in the central fovea. It's not contiguous with the disc, and satellite lesions may be seen. They can resemble macular serpiginous choroiditis, and the vision may be remarkably good in patients with this initially. These whitish lesions may persist in the macula for months and often replace pigment mottling and atrophy, but invariably, patients with this condition will develop choroidal neovascularization and disciform scarring, and the choroidal nevasculation is the result in the vision loss. Fluorescein angiogram, and I'll show you a picture, will show early hypofluorescence and late hyperfluorescence. There's usually not any leakage unless there's choroidal nevasculation present. There may be partial filling of these lesions in the late phases, but it's not going to look like AMPI necessarily, not as hyperfluorescent as AMPI does. ICG angiography will show central hypocyanescence that is persistent from these lesions, with these lesions. And again, these lesions are central, although multiple, all kind of clustered around the central macula. The OCT will show hyporeflectivity of the outer retina and ellipsoid zone disruption. And then we'll see variable loss of outer retina and long-standing disease. And of course, choroidal nevasculation can be demonstrated in the late phases of the disease process. Hypoperfusion of the choriocapillaris and OCTA that persists despite treatment is relatively characteristic and different from, for example, AMPI. And then you see in autofluorescence, this stippled hyperautofluorescence early, and then the hypoautofluorescence correlating to RPE damage in the later stages of the disease process. So here's a patient who has this jigsaw puzzle pattern of central hypofluorescent macular lesions here in the mid-arteriovenous phase in each eye. And you can see the characteristic changes with ellipsoid zone disruption and RPE changes as well in the central macula of both eyes on the OCT. The treatment is usually corticosteroids in the acute phase, but that doesn't seem to prevent development of choroidal neovascularization, and of course anti-VEGF therapy for choroidal neovascularization. Many times in the late stage of the disease, the patient will look like just AMD because they're 70 years old and they have choroidal neovasculation of the fovea and RPE disruption. So it's important in some patients who complain of symptoms such as photopsias and so forth to look at autofluorescence imaging, to look at angiography, ICG, and fluorescein to see if there's anything else going on besides just AMD, okay? So if you find patients have these unusual inflammatory type appearances on these tests, you may be looking at some variants of persistent placoid maculopathy, and I found many patients like that over the course of the last 10 years. AZOOR is a disease that affects young women more commonly than men. It can be bilateral, unilateral, it can be sequential in involvement. It can be associated with other systemic autoimmune diseases. Patients often present with photopsias, a very characteristic symptom, and development of scotoma with zonal visual field defects. The zonal involvement may start around the optic disc, so the patient may have enlarged blind spots initially, and then these defects can go along the arcade vessels and can be sectoral in nature. Patients often have a normal fundus examination, and upon evaluation may see nothing. In over 2 to 3 months, they may have vascular narrowing and zonal depigmentation and sharp demarcation between normal and abnormal retina. There can be annular variants of this disease, including white demarcation lines that are visible early. These are rarely seen. And I find that autofluorescence imaging, again, can be extremely helpful with this disease process. Fluorescein angiography may look normal early phases, but with later disease, you can see pigment mottling and window defects. So it doesn't really help that much. ICG angiography in the late stages can show this so-called trizonal pattern of normal appearing retina outside the AZOOR line, minimal leakage in the subacute area, and hypofluorescence in the area of choriocapillaris atrophy. And similarly, there is a zonal change that occurs in the OCT, where in the acute phase, you'll see disruption of the ellipsoid and the ellipsoid zone in the interdigitation line where the cone outer segment tips are present. And then you'll see thickened outer plexiform layer and loss of the outer nuclear layer. In the late phases, you may see RPE atrophy and persistence of loss of the outer nuclear layer in the ellipsoid zone. And of course, in the subacute or chronic AZOOR lesions, you'll see the trizonal pattern of this normal appearance outside the AZOOR line, drusen-like multifocal subretinal deposits in zone 2, the edge of the disease, if you will. And then, of course, in the old disease where there's photoreceptor RPE and choroidal atrophy. So here's a great picture that I have of one of my patients who had this zonal. So you can see this normal looking retina in the yellow line. The red line represents the area where you see the edge of the disease process, where you have disruption of the photoreceptors and these granular changes at the photoreceptor level and within the retina. And then as the disease becomes atrophic, you'll see this atrophy developing of the choroid. The choroid becomes thinner, and you'll actually see photoreceptor atrophy as well. Autofluorescence, again, is very, very useful, and we show a similar trizonal pattern with older lesions. Here's an autofluorescence imaging of a patient who has had some progression of disease over a 2-year period, very subtle progression. You can see old disease down at the inferior section and newer disease in the superior temporal portion with progression over a 2-year period. Very subtle progression, but definite progression of disease. And it's hard to follow these patients because many times they ignore the symptoms, and the symptoms can be very mild and subtle. Visual field testing can be useful to show progression of disease. ERG full field reduction can show some reduction in the A wave amplitudes. Again, standardization of ERG can be useful in following these patients as well. There is no treatment that's been proven effective, but I have in my patients shown some efficacy when we catch disease early onset with oral corticosteroids. We may be able to slow down the disease process. Unfortunately, I don't think there's any way to specifically prevent the atrophic changes that occur once the disease has started. Central vision is often spared in most patients, however, with this disease process. So here's another patient with very advanced AZOOR. They also have some drusen-like changes here, but you can see that this patient has pretty extensive kind of zonal involvement of the inferior half of the retina. Fovea is still spared. And here's another patient with evolution of the lesion. So you can see the active zonal lesion that then ultimately kind of goes away, but there's some subtle disruption of the pigment here occurring in the area of the activity. Here's another example of the zonal changes that we see that I showed you before. The atrophic changes in the inactive areas of old active disease, the marginal active or the leading edges where you see the photoreceptor RPE degeneration disruption with these excrescences in the RPE and photoreceptors, and then you see the normal edge. Acute macular neuroretinopathy, and we're coming to the end of the talk here, occurs in the 2nd to 4th decades. It's usually unilateral or bilateral. It can be recurrent. It can be associated with sympathomimetic drugs. There can be viral prodrome. Usually young, healthy people present with this disease process. The cause is unknown. OCT angiography, however, suggests that this may be a vascular insult to the deep retinal capillary plexus. So a deep retinal involvement. This is interesting, isn't it? This is not something that we understood until OCTA. The symptoms usually are paracentral scotoma and decreased vision. The central vision, the very central vision, is usually spared, even despite having this paracentral scotoma. The there may be one to small, very small, circular oval petaloid lesions that are probably best seen in infrared imaging, in my experience, and not so much autofluorescence imaging with this disease process. They can appear dark red to brown, and they may be surrounded by the normal appearing, compared to the normal appearing macula. The diagnosis is based on the clinical appearance and the course and the age of the patient, the demographics, because the fluorescein ICG tend to be normal. If you are lucky enough to have OCTA, that can be very helpful because of these deep retinal vascular plexus abnormalities, flow deficits that you see. And spectral domain OCT can show a hyperreflective band in the outer plexiform layer and outer nuclear layer, and disruption of the ellipsoid interdigitation zone, in the, which over the course of time will result in thinning of the outer nuclear layer. And this, there's some restoration of the ellipsoid zone with healing of the lesions. So here's a patient of ours that has acute AMN. You can see the infrared image showing those very characteristic kind of pericentral lesions, good vision, and you can see the disruption of the outer nuclear layer, as well as the photoreceptor in the ellipsoid zone here. And then as time goes on, there is some thinning of the outer nuclear layer that you clearly see compared to the picture above, and you can see that's a partial restoration of the photoreceptor ellipsoid zone. So very nice picture of that, of the OCT changes. The differential diagnosis can include vascular insults like pericentral acute middle maculopathy, which can look like large cotton wool spots, very different than the appearance that you see with acute macular neuroretinopathy. And the course of this disease, usually the central vision usually is stabilized and good and may improve. However, the scotoma may be persistent for a long periods of time. Sometimes they never completely go away. The acute retinal lesions usually fade, but you may still be able to see them on infrared imaging. There's usually no specific treatment that's bound to be beneficial. So I'm going to stop there. I appreciate your listening. I know I went over a little bit, but it's a very long topic, and I hope you enjoyed the presentation. I'm going to see if you have any other questions related to this talk. Looks like there is a question here from Nepal about mycophenolate not being available. If you have an older patient and mycophenolate is not available, I have also used azathioprine as as another agent. You can use methotrexate, but in Birdshot, I find that azathioprine is a good substitute because patients are usually older. Azathioprine I like to use in older patients. Again, anytime you're using immunomodulatory therapy like Cellcept or mycophenolate or azathioprine or methotrexate, you have to make sure that younger patients are aware that these can, this is associated with birth defects, etc. These agents, it should not be used if you intend to get pregnant or to impregnate someone else. So you have to have a long talk about with patients who are on these agents at childbearing age. And then tips about, someone is asking me, can you give us some tips about particular points that we should look for to make the differentiation among them? I hope that that was the tips that I could give you. I think the key is to look at the clinical history of the patient. Younger patients with viral prodromes with acute onset of changes, if they're bilateral, it's likely going to fall into that AMPI spectrum. If it's unilateral, it's likely MEWDS. Examination and the putting in your mind what the clinical pattern looks like, I think is really important. So, looking at good pictures of what these things look like and then translating that to what you're seeing is really important. Now, some of these diseases like AZOOR, acute macular neuroretinopathy, these are difficult even for patients who see a lot of this kind of condition. So I would say pattern recognition is particularly important. So in your experience, are white dot syndromes linked to systemic inflammation? There are some, as I mentioned. As you know, systemic diseases, AMPI can be associated with cerebral vasculitis and other viral prodromal illnesses. Multiple evanescent white dot syndrome usually is preceded by a viral prodrome. Diseases like Serpiginous have been associated with systemic vasculitides, as I mentioned. Birdshot's usually not. Birdshot uveitis is usually not. Multifocal choroiditis, pan-uveitis, simply because of the clinical appearance, you have to rule out systemic associations before you come up with the idea that this is an idiopathic condition. So it's a diagnosis of exclusion. And serpiginous choroiditis has been associated with some autoimmune disease processes and viral diseases. But again, the treatment is immunosuppression. Next question is, how do you remember all these diseases? You know, it's like anything else in medicine. You have to see a lot of it. You have to keep seeing it every day to remember it. You have to think it. So I think it's really, really hard to memorize all of these things. But for me, after 25 years of doing this, it's easier because I've seen every one of these things. But I think I will tell you a couple of things to keep in mind. If you have access to fundus autofluorescence imaging, that is extremely helpful in white dot syndromes like MEWDS and AZOOR. I do find that ICG angiography and fluorescein angiography combined with autofluorescence can be very useful. If you have a spectral domain OCT, looking at subtle changes, looking at those spectral domain OCTs very carefully at the ellipsoid zone that correspond to lesions. This takes a little bit of time and a little effort, but that can be very, very helpful and can help you delineate what's going on.